I'd like to introduce Professor Ganesh Moorthy. Thank you very much for joining us very early in the morning from Children's Hospital of Philadelphia. So Dr. Moorthy is working on the development and validation of VAMS methods for the analysis of cefepime, voriconazole, furosemide, and vancomycin, and looking at implementing them for pediatric clinical research. So if I can pass over to you.
Thank you, Susie. I hope you can hear me okay.
We can, thank you.
That's great. Get my slides.
Okay. Excellent.
Yeah. All right. I'm learning a lot. It's amazing what's happening in your research program. That's learning a lot. So I'm going to take this opportunity to share some of the work that we have been doing at Children's Hospital of Philadelphia. So I'm collaborating with Dr. Kevin Downs. So he's an infectious diseases attending physician at Children's Hospital of Philadelphia, and also Dr. Julie Fitzgerald and Dr. Athena Zupa. They both are intensive care attending physicians at Children's Hospital of Philadelphia. So I'll be talking more from a bioanalytical perspective in the early part of my presentation, really focusing on one antibiotic drug that we have been working on for the last 3-4 years, which is vancomycin. Again, moving from a traditional plasma-based pediatric pharmacokinetic studies to whole blood microsampling, it has been fascinating in the context of really using a small volume blood samples to conduct these studies. On the other hand, it does bring in some of the interesting challenges from an analytical perspective in terms of working around like hematocrit. That's something Susie mentioned earlier, which could be sometimes challenging to interpret the data depending on the blood to plasma partitioning. So I'm going to talk in the context of like assay development, validation, and implementation of a microsampling assay. And also, we have conducted a small pediatric clinical research study to really compare the capillary versus arterial or venous sampling in pediatric population, and with the ultimate goal of really correlating the whole blood microsampling data to the plasma data. This is something that Dr. Kevin Downs and Dr. Zupa is in the process of collaborating with Susie's team. So moving on to our research laboratory, we kind of work on a variety of therapeutic areas as a Center for Clinical Pharmacology. We have developed some of the microsampling assays for voriconazole and also some of the cannabinoids, and we utilize this cannabinoid assay for doing some remote sampling studies with pediatric autism population. And I think more recently, we have been focusing on antibiotics. We have studied the cefepime pharmacokinetics in a sepsis population in a pediatric study. And currently, there are multiple studies utilizing vancomycin assay in the context of sepsis studies. Also, in collaboration with neonatologists within our hospital, we have been recently studying the furosemide pharmacokinetics, both from microsampling perspective as well as comparing to urine assay. So our laboratory is equipped with two standard triple quarter pole mass spectrometric system as shown here. And we provide the coverage for a variety of therapeutic areas. So as Susie has earlier mentioned, we have started using this VAMS, which is also called Mitra tips from Neoterex, to perform some of this microsampling studies. They do come in a variety of volumes from 10, 20, or 30 microliters. So for vancomycin study, we have used a 20 microliter VAMS tips. Recently, we have published this work in the Bioanalysis Journal. Um, and in terms of vancomycin, as all the audience know, it's a chemically very interesting compound, which brings in some of the analytical challenges early on, especially working with small volume. Um, However, since the compounds were quite sensitive in our instrument, we were able to really develop a robust assay within acceptable range for the purpose of the clinical study. So this is a representative chromatogram of parent vancomycin drug on the left side, and an internal standard compound atenolol on the right-hand side. So later on, in the beginning of the study, we started with atenolol. However, we were able to receive vancomycin D12, which served as a much better internal standard because it's structurally identical, and we're able to provide much more robust data. Again, some of the information on the mass spec conditions and the chromatographic conditions are listed below. And so this method has been like very robust in terms of working with a small volume of blood samples. This is a typical scheme of how the validation studies are done. So we collect blood from a healthy volunteer, then we prepare calibration standards and quality control samples within the range indicated here. And again, based on FDA guidance, we prepare 2 sets of calibration curve and 6 sets of quality control samples, and perform 3-day validation and several other standard validation experiments. So again, in terms of the sample processing, both in the laboratory setting as well as clinical setting, so the 20 microliter blood samples is collected in this Mitra device, and it's left to dry for 3 hours at room temperature. Then it's extracted, then purified further with solid phase extraction microelution plates. Then LCMS analysis is performed. In the context of clinical setting, we have established that vancomycin is stable at least for a week at room temperature. So there is some level of flexibility for the clinical team to collect multiple samples and bring them to the laboratory within the next couple of days. So this is a typical validation parameters from a 3-day validation, where we look at the accuracy and precision of quality control samples at the lowest limit of quantitation, in this case 1 microgram per ml, and low, medium, and high quality control concentration levels, and really look at the mean and standard deviation of 6 measurements, and then calculate precision, which is supposed to be within 15%, and accuracy, which is acceptable if it is within 85 to 115% for low, medium, high QCs, and within plus or minus 20% for the lowest limit of quantitation. So as you could see, the assay was reproducible across 3-day validations, and also looking at the inter-assay variability over 3 days, we can see the assay was quite reproducible. And without getting into a lot of details, we went through and completed a series of standard validation experiments to evaluate specificity, selectivity of the method, and also look at the recovery and matrix effect of the extraction conditions, and look at the dilution integrity to make sure the samples would provide a reliable number if it have to be diluted, and also look at auto-sampler stability to make sure that in case of any reanalysis, the data would be still reliable. And in terms of batching samples for clinical analysis, we established that the samples stored at -80 are stable for over 5 months period. Again, we have found that it's stable for at least a week, and also looked at blood plasma and VAMS comparison to based on in vitro samples to have an understanding of how blood and plasma values relate in this case. I think the one thing also we looked at it is, as Susie mentioned, we looked at the impact of hematocrit on the quantitation of vancomycin, really looking in vitro in terms of low hematocrit such as 25% and normal hematocrit in the range of about 45%, and also looking at a high hematocrit of about 60% and see how it impacts quantitation of vancomycin. So once assay is validated, we have implemented this to two ongoing clinical research studies. The one is the first one is comparison of antibiotic sampling techniques, which is called COAST study, which is really looking at a correlation between microsampling via finger stick, which is really capillary blood, versus arterial or venous sampling collected at the same time within 5 minutes of the study. And the second ongoing study also looks at vancomycin and acute kidney injury in a sepsis treatment. Study also utilizes this assay for vancomycin pharmacokinetic analysis. So I'm going to talk briefly about this COAST study. Again, as we have seen earlier, we performed the validation or sample analysis using a scheme on the left. On the right-hand side, from a clinical subject, either a venous or arterial sample is collected, and at the same time, finger or heel stick samples collected. Then they have been dried and then sent to the laboratory for VAMS analysis. And in addition to that, blood sample is collected from the subject, and it was sent to the clinical laboratory, which is there's a CLIA certified lab looking for plasma concentration of vancomycin for clinical decision making, and utilize that assay to compare the outcome of vancomycin plasma assay to what we measure with this whole blood VAMS assay. And this is the results from the first 3 subjects that at the time of the publication, where we compared a venous blood concentrations from the VAMS to the capillary. As you could see that there has been a pretty good correlation across all these 3 subjects. And also at the same time, we have measured the plasma concentrations from the clinical core lab. And I think 2 out of 3 cases, we do see a good correlation. However, we wanted to see how this really applies to the larger cohort of subjects. As you could see, this COAST study, we enrolled 32 pediatric subjects, out of which 31 with samples collected and 30 with at least 1 evaluable pair of samples, and 22 evaluable pair of capillary plasma samples was in the study. And some of the issues that we have encountered is at the time of clinical sample collection, sometimes the samples were underloaded, meaning that the mitra chips were not fully collected with blood samples for maybe a challenge of collecting appropriate volume of blood. Or in some cases, there are overloaded tips where the blood was much more than 20 microliters and has been visibly much higher, and so we kind of classify really looking at the mitra tips as so underloaded or overloaded. And so there are a few cases where the sample collection were more than 5 minutes apart, so which again resulted in not being close enough to make a good correlation. So out of the 28 evaluable pairs of venous arterial plasma samples, 1 was underloaded and 2 were overloaded. So overall, at the end, we had 20 pairs of capillary venous VAMS samples. So this is an unpublished results from Dr. Kevin Downs and authors listed below. So as you would see that this is the results from correlating arterial venous VAMs on the y-axis versus capillary blood on the x-axis for vancomycin. So this is the entirety of the data. As you would see, there's a reasonably good correlation. However, there are some outliers, and we could not figure out why that particular subject and samples did not align in spite of performing all the deep analysis and including repeat analysis of the second backup VAM sample. So there are some outliers. And when we exclude that outlier, we do see a reasonably good correlation of like Pearson R-square of 0.975. That's so that the technique has a promise. And I think the next key step is how this blood concentrations really relates to the plasma concentrations, which is currently used as a gold standard in terms of therapeutic drug monitoring and decision making. So in summary, we have developed a VAMS assay for vancomycin and implemented for the pediatric clinical studies. And our initial analysis saw a good correlation between capillary versus venous arterial blood samples. And the correlation analysis of measured whole blood VAMS concentrations of vancomycin to the corresponding plasma vancomycin concentrations is currently in progress. I think Dr. Kevin Downs and Dr. Zupa are also collaborating with Dr. Zuzi Parker to further expand this analysis. With that, I would like to thank all our colleagues at Children's Hospital of Philadelphia who made this study possible. Thank you, and I'm happy to address any questions that you may have.
Thank you very much, Ganesh. Thank you for talking us through your studies. Very interesting results. And yeah, certainly there's the challenge of the whole blood to plasma. You know, that correlation is a challenge I think many of us will have seen.